Can you tell me about the cancer thrombosis pathway?
Yeah, so again, this was an area that we've probably invested most in recent times, and it goes back to about 3 or 4 years ago, where there was a study published called the Pelican Study by Professor Simon Noble that showed that there was a lack of understanding and awareness of thrombosis in cancer patients. And when he interviewed patients, a lot of them found that their management wasn't as they would expect. So many of them made parallels to the fact that if they considered their cancer diagnosis and their cancer treatment, they were given lots of support, and there's various healthcare professionals involved. However, when they subsequently went on to get diagnosed with a VTE, and just to give that some sort of context, 20% of cancer patients will go on to develop a VTE. They actually found that they weren't given that support in the same way. So we thought, well, we've got a VTE service, we're seeing cancer patients, how can we make this better for them? And so what we did was we developed a specific cancer-associated thrombosis pathway, whereby we had every single cancer thrombosis diagnosis come through our pathway within the health board, and we would manage them from initiation to that 6-month decision, because with cancer-associated thrombosis, 6 months is generally the minimum duration. And much of our focus was around easing anxieties and improving patient education. And so we undertook some research, and we did some basic anxiety scores where we showed a clear benefit of our service. And we also did some knowledge retention studies. And again, we saw a clear benefit in terms of patients being far more well informed with our service compared to the previous service.
Interesting. I understand that you run a hematology clinic once a week. What does this involve?
So this started a couple of years ago, and again, I moved into this quite organically. So initially it was set up as something completely different. Back then, the majority of DOAC initiations were undertaken in secondary care. So it was primarily set up as a method of dealing with GP referrals for AF patients to be initiated on DOACs. But as with the vast majority of the UK, that's now moved more into a primary care domain. And as such, the clinic has evolved with my interests in thrombosis and anticoagulation to be more of a specialist thrombosis and anticoagulation clinic. So the majority of the cases are GP referrals for complex anticoagulant or thrombosis patients, where they get referred to hematology and they'll get reviewed by myself, and we'll come to some form of treatment agreement in terms of how we'll manage patients going forward. So quick examples would be things like VTE at unusual sites, antiphospholipid patients who require complex bridging arrangements, just these sort of complex anticoagulant patients.
Again, much more than I realized going on there. I wonder, would you like to make a comment about being independent prescribers? I mean, could you do this work if you were not independent prescribers?
Interestingly, we did to an extent. So we gained our IP qualifications relatively recently in 2018, actually. And I mean, we were running the service for 4 years, 2 to 3 years realistically, with us being some of the primary clinicians. And I think the single most important thing that to develop in terms of our service was that we all gained IP qualifications, because it just allowed us to then become independent practitioners and develop the service as we wanted to. Whereas prior to that, it was quite difficult to make those independent decisions, because you were fundamentally relying on somebody else to prescribe the medication for you, which was fine because we had a good relationship. But the major change has been that we're able to do it as independent prescribers.
Now, I have to ask this because it's a criticism that's occasionally raised. Does your service risk de-skilling junior doctors when it comes to anticoagulant prescribing?
I don't think so. And I think the main reason is that we've made such a positive contribution to VTE management and the health board. So when we came in, we identified numerous aspects of VTE care that weren't in line with evidence or guidance, and we've been able to improve on those things. But in terms of, I don't feel like we've de-skilled other healthcare professionals. I think we've upskilled them, and mainly through our education that we've undertaken, through the guidelines we've developed. And I was reflecting on this recently because I think one of the proudest things I have is that when I hear junior doctors quoting elements of management that I know that we've put into guidelines, I kind of think, well, they weren't saying those things 3 or 4 years ago. So it makes me feel quite happy that I feel we've actually made a positive contribution and probably upskilled the junior doctors to some extent.
That's very interesting.